sides. I promise it's different.
Oh, yeah.
I got to hold a knee.
Okay. So,
I got to hold a knee.
was this on a clinical?
No.
Okay.
It wasn't semi-clinical. I was up at the L&D. I got to observe.
Okay. How many of you guys have had an OB or a GYN problem while you're doing clinicals? In the ER? None of you?
Oh, in the
Abdominal
ER,
pain
yes.
due to her pregnancy.
Okay.
And abortion.
Well, the reason this is really important to know is because, believe it or not, you're actually going to encounter these patients, and you're going to encounter them more than probably some of you care to, right? I've got one delivery and one that I had to tie off, or actually the neighbor used a shoestring and tied off the cord, and we cut and we went from there, okay? So this is something that you are going to run into. You are going to have to know. The answer is not always diesel, okay? Sometimes it is, and we're going to learn about what those are whenever she gets situated.
There we go.
Okay, so in order to understand some of this OB and GYN problems, you got to kind of understand the female reproductive system, if you will, okay? The uterus is that thick, muscly wall where the zygote would implant, okay, that grows and basically holds the baby. That becomes the baby's house, right? The ovary, what you have to understand, in this picture, it looks like it's attached. They are not attached, okay? So at the end of this fallopian tube, there's a bunch of cilia, or hair-like fibers, and it's kind of all wet. It's all fluid. And the ovary kind of pops out the egg, and the hairs, the idea is the hair kind of sweep it in. The fluid motion of the hair sweeps it into the fallopian tube. They are not attached, okay? And then you have the cervix, and that's kind of the opening of the uterus. And then you have, of course, the vagina. All right, and so this is kind of what it looks like from the front. So you see that the uterus sits right on top of the urinary bladder. And it's important to understand, and I know everybody's going, oh, God, right? But it's important to understand the rectum, because there is going to come a point before you deliver a baby that the woman is going to tell you she has to move her bowels, she has to go to the bathroom. Don't let her go to the bathroom. We're going to talk about that later. But remember this picture and understand maybe why she feels that pressure, if you will. Okay? You need to ask specifically, when was your last? And look at that. Normal is stressed. Last normal menstrual period. Okay? Why do you think we ask about normal menstrual periods? We mentioned it here in this class or something else. I don't even remember.
Because pregnant women can spot.
Pregnant women can spot, and sometimes that they don't know they're pregnant. Okay?
Abnormal changes can signify that you have a tumor or cancer or something else.
Okay? More specifically to kind of what we are going to use it for, okay? Women often have, some women have what they call implant bleeding, and that happens just early of their period, but it's usually lighter. And they will commonly associate that with having a period. So they will say, no, I can't be pregnant. Okay? So that's important to note. If there are changes, there's always the possibility. Okay? And then you need to kind of know about abdominal pain, what's the location, and the quality. And you're going to understand a little bit more about quality because it's going to give you pretty significant indicators for some conditions that these women are going to run into or that you're going to have to run into. Okay? And then, do you have any vaginal bleeding or discharge? I understand it's a very uncomfortable thing. Gentlemen, get comfortable with it. Okay? If she sees that you're, this is just like, a dad talking to their daughter. If she sees you're uncomfortable with it, she's going to be uncomfortable with it. Okay? But it's important medical assessment. This is some information that we all absolutely need to know. All right, so they are potentially pregnant if they've missed a period or it was abnormal. Okay? If they have nausea and vomiting, increased urinary frequency. Now, keep in mind, some of these things won't register to her that she's having increased urinary symptoms until maybe she starts kind of thinking, hold on, when was my last normal period and maybe I'm pregnant. Okay? Breast enlargement or tenderness, and then also some vaginal discharge. You can ask if they're sexually active. Okay? Be cautious about how you ask, when and where you ask, and the appropriateness, okay, when you're asking. All right? But how many of you are married? How many of you have significant others? Female type? So let me tell you, in case you don't know, most of these are very common premenstrual symptoms as well. So it isn't uncommon, again, for a woman to tell you, no, but I'm about to have my menstrual period. Well, when was your last? When should this one? Well, it's a couple days late, but I know I'm about to start because my breasts are sore, you know, this kind of stuff. That doesn't always mean that it's coming. All right? Some women just don't know. Okay? So, let's talk about terms. Para means number of live births. Gravida means number of pregnancies. And the way I remember that, parents, para, how many kids are you parent to already? Okay? Just a little kind of tidbit of information. And then abortions. This is a very harsh term, especially to a woman that you suspect is having a miscarriage. The medical term for a miscarriage is called a spontaneous abortion. Okay? It's okay that we know that. Be sensitive, ladies and gentlemen, about how you ask her about abortions. Okay? Be cautious about the terms you use. Because if you ask a woman who's miscarried if she's had an abortion, she's going to be devastated, especially if it was a wanted pregnancy. Okay? So estimated date of confinement, and that's actually what they call it. Your due date is date of confinement. All right? It is what it is. So here's how you do this. You subtract 3 from the month of the last menstrual period and add 7 to the date. Okay, so you go back 3 months and add 7 days, and that'll give you her due date. See how they come up with that? So if I tell you my last menstrual period was July 15th, what was my due date? What will be my due date?
So that would be March. So it was July, it's the 7th. So go back to the 4th, right? April. April will be your last menstrual cycle. And then,
Okay.
Bingo.
Shall I help y'all?
April
Yes.
20th?
So, July is the 7th month. Take away 3. What month does that give me? 4. It gives me April. Now add 7 to the 15th.
27.
I'm almost due. Oh my goodness. That was a pretty good guesser.
Oh my goodness.
Okay? So you see how to kind of figure that?
that's what you're figuring for the last menstrual cycle, right?
Yes. So it's based on her last menstrual cycle. So women, do you guys know how long a term pregnancy is?
10 months.
40 weeks. Okay? Because they use that last menstrual period for day 1. Okay? It's important to know that. Right? It's also important, true story, I went on a patient that's going to fall into a different category that we're going to talk about tonight. She was working at a local fast food restaurant and called us. She was kind of round in the midsection, which is okay. Called us and said, my water broke. I need somebody to take me to the hospital. Cool. So we go and I'm thinking, woohoo, baby's going to be born today, right? What a great day. So we pick her up and sure enough, her pants are wet. She's round in the midsection, a little bit. I asked her due date in her last menstrual period, and she gave me dates, and I was kind of scratching my head thinking, something doesn't sound right, but okay. And so she has to go to labor and delivery, and so I call labor and delivery, hey, she's coming. And I took her up there, and she had wet her pants, and she was crazy and not pregnant. Okay? So it is important to kind of add up those dates and see, because I was just kind of like, okay, you know, maybe she had spotting after her pregnancy, right? It just didn't, because I was like, how many weeks are you? It just didn't add up to me. But by that time, we were already at the hospital, so we took her upstairs and woohoo, and yeah, it was a great day.
That's awesome.
So it's important to know. All right, so for part of your OB-GYN assessment, so you need to kind of say, if they go, I'm pregnant, you need to know, okay, well, you need to know a lot of questions. One of the big ones is, are you receiving prenatal care? It's amazing to me how many women in this country do not receive prenatal care. Okay? The other thing is, how far apart are your contractions and how long are they lasting? Okay? closer they are together, the longer they last, closer you are to a baby being born. Right?
Are you going to be going over how to properly count that later?
Yeah.
Okay.
Well, I think so. We can talk about it.
Okay. Well,
Let's talk about it.
All right, because when my wife was pregnant with our first, I thought the way you counted was when she had, at the end of one, that when she had her last contraction, when it finished, to the next one. And then that's why I counted.
And it's start to start.
And that's why I figured last time, I just wanted to confirm with that part.
Yep, it is start to start. But one of the things you do need to know is if they are a minute, right? If she's contracting, say she's contracting every 2 minutes. So what we want to know is how long is that contraction lasting? So how much time do we really have in between as well? So I want to know how far apart the contractions are, how often we're having a contraction, but I also want to know how long each contraction is lasting. Does that make sense?
How long do they usually last for?
Depends. It really depends. So the closer she gets to delivery, the more consistent they're going to be. So some of them may last a minute. Some of them maybe last 30 seconds.
Does it just feel like a cramp or like a flexing?
Yes, it's intense cramping. You can feel the outside of the abdomen and feel contractions. So, and we're going to talk because if you feel the tip of your nose versus your chin, okay, that's some of the differences. Okay?
Sounds awful.
It's wonderful. So, you need to know kind of some things about their vital signs. So, hypertension. Here's what you have to know about this. Hyper and hypotension. Women gain 30 to 40% of their blood volume increase. Okay? 30 to 40% more blood volume, and that happens in about the second trimester, early in the second trimester. Okay? So, what do you suspect typically happens to their blood pressure? Yeah, it goes down a little bit. Okay? So, a pregnant woman is considered hypertensive if it is above 140, I think it's 140, or, no, it's got to be 130. Or, and we'll get into it more later, or 20 points above her baseline. Okay? And then, also, watch out for hypotension. Now remember, mild, okay, a mild drop in blood pressure is pretty common. Okay? It still shouldn't be extremely low, except for in the case of our good friend Marcy here, right? Because she was very small to begin with, so her blood pressure probably wasn't very high initially. Okay? Most of them will still be over 100.
How would having more blood lower your blood pressure?
Because you don't have to work as hard to circulate it. There's more to circulate. Make sense?
Yeah.
Okay. And then if you suspect that she's got blood volume loss, you absolutely need to do a tilt test. You guys remember what a tilt test is?
Yeah, sit, stand, yeah.
Yep. Lay flat, sit up, and stand. Okay? Wonderful. So for focused exam, you want to look at edema. Now look, all pregnant women get edema in their feet. Okay? What you really want to look at is their face and hands, well, and their feet too. So don't exclude that. Okay? But edema in the hands and face are more concerning, and we're going to talk about a medical condition that's life-threatening to both mother and baby here in just a little bit. Okay? So let's talk about some gynecological emergencies. Ectopic pregnancy. An ectopic pregnancy is basically a pregnancy that happens anywhere outside of the uterus. Okay? I mean, that's the definition. 95% of them are in the tube. Okay? Here. All right? This is absolutely 100% life-threatening. So let me explain to you kind of what happens. When a woman gets pregnant and the cluster of cells, right, it ends up being a cluster of cells that they call a zygote. The outer layer of the cells actually eats into the lining of the uterus. And that's what then forms the placenta. But if it attaches in the fallopian tube, it does the same thing, right? It attaches in the fallopian tube, for example. Well, when a woman gets pregnant, her body kind of recognizes this long before tests, okay? And we start increasing blood flow to some areas because we have to feed this parasite, okay? So my body's pumping extra blood down here to my uterus and this kind of stuff, and okay? And then the fallopian tube, we have to understand, is that uterus is really stretchy, okay? It can grow significantly to hold the baby. Fallopian tubes do not. So there will come a point that it will rupture. Okay, so now you have a ruptured tube, and you have increased blood flow to that area equals a fast bleed. This is absolutely life-threatening to mother. At this point, the baby is already non-vital. There is no survivability for the baby whatsoever. Okay? Everybody kind of understand that? They can attach to anywhere from the liver to the ovary to the outside of the uterus. They can attach anywhere. Typically, though, where you see it is it gets into the fallopian tube. It just doesn't make it all the way to its destination. And that takes about 7 days, I think, to make its little way down there and start actually implanting.
So when do we find out? When is that noticeable? When do we go, hey, you have this?
I think it tells them, hey, I know, but, okay. So here's what happens. Some people may miss a period, okay? Some may not. They may think they haven't missed a period because maybe they had that implant bleeding, okay? But again, they may have a lighter period because it's all about hormones. My hormones tell me when to slough that lining. Hey, we didn't get anything this month. Slough the lining, that's what the period is. Then the body starts to build that lining back up for implantation for the next time, okay? So any other signs and symptoms of early pregnancy? Be very cautious. This is typically between 6 and 8 weeks. Okay, here's the problem. The home pregnancy tests. Okay, do you guys know what they test or what they...
They're looking for a hormone, aren't they?
Yes, they're looking for the HCG hormone. Okay, but the pregnancy tests that you buy over the counter are typically like 25 units. Some of them are 50 units. All right? And so, typically your HCG doubles every 48 hours. Right? So that hormone in my body doubles. And 2 days later, that doubles. Okay? So it grows pretty rapidly. But you don't start producing the HCG until the fetus implants. If it implants anywhere other than in the uterus, the HCG levels do not double every 48 hours. So she can very well have a negative home pregnancy test and still have a tubal pregnancy because the HCG levels aren't high enough to detect it. Everybody with me? Which is why it is very important. If she goes, yeah, my period came a few days early. Okay. Oh, but it was lighter than usual. Okay. Are you sexually active? Yeah, I am. Oh, my. And she's having lower abdominal pain. This is a life-threatening emergency period. All day, every day. Okay? It may radiate to the shoulder. Again, that blood kind of gets into the abdominal cavity and you have that referred pain. Okay? Positive tilt test, again, because they're bleeding. Now, my medical director, Dr. McGraw, actually gave me statistics. Go back a few slides for me. Oh, nope, there you go. This right here is the most dangerous place to have an ectopic pregnancy.
Which way?
The one closest to the uterus.
Okay.
Because it has more blood supply and more blood volume. 1. 2, that part of the uterus doesn't stretch. So you'll actually rupture the uterus. The statistic that she gave me, how long do you think it would take for a woman to exsanguinate or bleed to death from a ruptured pregnancy right there at the uterus?
20 minutes?
4. She can actually, it's not common, okay? It doesn't happen, that's an extreme. But it can happen in as short as 4 minutes. Okay? They will start having pain before rupture. It's important to recognize it early. Okay? You can go ahead. Oh, yeah. Okay. So they may not have abdominal pain. Wholeheartedly, it depends, right? I actually personally know a person who had a tubal on one side. They had to do a tubal. They cut a piece of the tube out, right? Kind of burned it, did whatever, sewed it up. Went to the other side, had a tubal on the other side, lost that entire tube. They had to take the whole tube. The first tube grew back together. She had another tubal pregnancy and almost died.
Holy crap.
Okay? Again, she's a rare case too because that doesn't happen often. But so you need to watch for any signs of hypovolemia, any signs of hemorrhagic shock in a woman of childbearing ages. Sir?
Is this the same as like someone trying to
No. No. No, ovarian cysts are not life-threatening whatsoever. Okay? And again, some of them may not have had a missed period. Okay? All right, we've covered all those, right? Excellent. Lower abdominal pain, unexplained hypovolemia. Okay? Shock in a woman of childbearing ages. What is childbearing ages?
From 12 to...
We're talking 9 or 10. 9 or 10. And don't be fooled if she says, I'm going through menopause. She's still of childbearing ages. Okay? Some women later in life start thinking they're going through menopause, but maybe they're hot and having hot flashes and haven't had a period because they're going through menopause when actually they're pregnant.
So what is childbearing ages then exactly?
9 to 90.
Oh, okay.
Okay, not 90. Yeah, absolutely. Absolutely.
That's a statistic.
So you're
we gotta
safe
look
to
up
say-
the oldest pregnancy.
Actually, I can give you some of the information on that, but it wasn't a natural pregnancy. This was on the I didn't know I was pregnant. And she was a 70-year-old woman who was married to a much younger man, and they actually implanted. She did in vitro.
Yeah.
They said it didn't take. That it took, but she miscarried. Come to find out, she miscarried one, carried another. Okay, and for some reason, and it doesn't happen much in this country. I think it's over in, is it Europe?
Yeah, it's good.
Europe is pretty common for them to kind of start later on in life.
I think they done this one last class, wasn't it like 7 or 8 or something? Didn't you see a thing? Didn't we have somebody looked it up and there was like a 7 or 8-year-old?
Oh, I don't know. It's common. It really is common, and I don't know if it's the hormone in the beef or chicken or what. Girls are starting their periods earlier and earlier all the time. I'm telling you, if she's 9 or 10, you probably need to ask. Okay, the youngest I think I've seen pregnant was 10 or 12, and she was pregnant by her stepdad.
I saw that too. Same thing.
So don't ever assume she's too young and couldn't be pregnant. Okay?
The girl I saw didn't even know. When they asked her how she got pregnant, she couldn't explain what happened because she didn't understand.
She's too young to know. Yeah, absolutely. Y'all recently heard about the 15-year-old girl that hung herself. Did you guys hear about this girl? She went to a party, and they don't know if she drank so much she passed out or that she got roofied and passed out. 3 16-year-old boys had their way with her and took pictures. They plastered it on internet. They put it up at school. They did all of this. The girl hung herself. All 3 of the boys currently have 2 felonies and 1 misdemeanor, and that's before they decide whether they're going to charge them with manslaughter.
See, I thought I heard it. Didn't she must have done it like a few days later, right?
Yeah, because they started putting it all up. I mean,
Yeah.
So that's like here?
I don't know where it was at, honestly.
I don't watch the news.
Youngest girl ever. No, it's like West Virginia or something.
Give birth?
You looked that up just now?
Yeah, there's not.
Wasn't it on
That's-
Wikipedia?
Okay, that is an extreme. I wouldn't ask commonly if a 5-year-old is, but a simple way is to say kind of, maybe, hey mom, has she started her period yet? I'm going to tell you, little girls are not, oh, that's horrible. Little girls are not comfortable to discuss this. Okay? It's an uncomfortable thing even for them to talk about sometimes with mama. So it is appropriate to kind of go, mom, has she started her period yet? This kind of thing. Okay? Again, 5 is uncommon. 9 or 10, pretty regular. Okay? So what are we going to do for this ectopic pregnancy? Transport immediately. High flow O2. Why are we going to give her high flow O2? It doesn't say anything about her SATs. It doesn't talk about shortness of breath.
She needs the oxygen.
Well, okay, so you're right. She's in shock and she needs oxygen. Why?
So she
Because the baby's taken away all of it?
there ain't no baby after this point if it ruptures.
Hemoglobin, right? Hemoglobin. So yes, I just want you to recognize that you have to have hemoglobin. And so remember, you could put your pulse ox on and it could say 94%. What is the pulse ox measuring? Bound circulating hemoglobin. So if she has 20% blood volume loss, she's already dropped 20% of her ability to carry oxygen, but you would never know that because it's all telling you about circulating bound hemoglobin.
But she's pregnant, so she still has an extra 10% in her system.
Nope, actually this happens at 6 to 8 weeks and you don't get that 30 to 40% until the early 2nd trimester.
Okay, you got it.
I know. So supportive care for hypovolemic shock and then transport immediately. And yes, emotional support, y'all. Okay. Pelvic inflammatory disease, or PID. And you're going to hear this called about the PID shuffle. Okay? It's true. This is typically acute or chronic infection. It's often caused from sometimes, and it's related to undiagnosed or untreated chlamydia a lot. Okay, it is basically an infection of the fallopian tubes, ovaries, uterus. It can be in the peritoneum. Okay, any of those. I said chlamydia. I'm sorry, it's gonorrhea. Okay, staph, strep, coliform bacteria. Okay, there's lots of infections. One of the telltale signs that they have PID is it's difficult for them to move. So they will be kind of hunched over, and they're going to be holding their abdomen, and they're going to shuffle their feet because it hurts so much to pick them up. That's why it's the PID shuffle. So if she's holding her lower abdomen and she's kind of shuffling her feet, I bet you she's had her period 2 to 3 weeks ago. Just saying. Go ahead. So, high flow to and transport. She needs antibiotics. Okay? And this can actually cause infertility.
That's not life-threatening at all.
No, she's going to be sick. I mean, it's an infection like anything else. Right, well...
If she didn't treat it, would it be more like sepsis?
Yeah. I mean, eventually it could go into sepsis, sure.
Okay.
They would treat it long before that because, it's, from what I understand, it's pretty painful. I think I've had one patient that had PID.
Did you go over this one? This slide?
Nope.
I must have missed it.
Nope. So some symptoms, lower abdominal pain. There you go. Oh, I'm sorry, it's 1 to 2 weeks. So gradual onset, 2 to 3 days, 1 to 2 weeks after her last period. She's going to be showing signs of an infection. Fever, chills, nausea, vomiting, right? Just like when you have an infection of any kind. She may have yellow or green vaginal discharge. Okay? Some of them will just outright tell you. Okay? Others you may have to ask. Okay? It is an appropriate question. Where are you going? Okay. Oh, now I know why you moved on. Go ahead. Very good. You went twice.
This one we've already gone over. High flow to.
Oh, okay. Go ahead.
transportation.
Sorry.
I missed it about 2 slides ahead. And
Okay.
I found it on my own.
I'm going to have a new clicker.
I didn't purposely.
I'm just kidding. I'm just kidding. So spontaneous abortion, okay, is also called a miscarriage, okay? Again, women will call it a miscarriage because when you say abortion, it's kind of like, for a lot of people, it's that dirty word that they don't want to hear about. Okay? Y'all heard about what's going on in New York?
No.
There is a doctor that owns a abortion clinic. He is on trial for murder, and there are several cases where he did late-term abortions after 24 weeks, delivered a baby. Staff says he would deliver babies that were crying, and he immediately snips the spinal cord and basically does a decapitation of late-term abortions.
Yeah, my friend told me about that.
And he was showing his people how to do it and whatnot. So,
How did he justify that?
it's an abortion. Do you want me to tell you how they do abortions in utero? They pull the fetus apart.
Well, the only reason I'm asking that, I knew that there's a certain time where you can't do it. I mean, how does he blatantly ignore the rule? You know what I mean?
I'm going to guess that's probably why it's on trial.
Sure, yeah.
But some places, I think some places allow late-term abortions.
Oh, okay.
I do believe some places allow, and basically they put you into labor and you deliver the baby before it's
Like a
survivable.
stillborn birth.
Except the baby will still be alive, right?
Well,
And it'll suffocate.
abortion is legal if it happens in utero, but if it happens, and that's the big deal, is once the baby is delivered, it's murder. So
Is that because if it's inside, it's not considered a person yet? Isn't that
I guess
true?
that depends on who you ask.
Well, I mean legally.
Too.
Isn't it not a person if it's not born yet? I'm not saying I agree with this. I'm
I-
just saying is that
The answer is I don't know why they say it's legal in utero and not.
okay.
That's my answer.
How do they do it, just out of curiosity?
You said
They pull the baby apart.
Like,
How they pull them apart?
They pull pieces out and then they make sure they got everything a lot of the times and kind of do suction.
didn't they used to use a vacuum?
Yeah, they still suction. They still do that. Yeah, it's a very gruesome
Don't joke about abortion, please.
type thing. Actually, he's not joking. That is what they used to do. Before it was legal, it was happening in kind of back alleys and dirty places, and a lot of women would die or become very sick because of infection, because of a partial abortion will cause an infection. So if she hasn't an abortion, whether it's a miscarriage, intentional or unintentional, it can actually cause, so tissue will cause her to become very sick.
Haven't you seen Dirty Dancing?
I always thought, I'm sorry for the comment, but I always thought, because to me, a clothes hanger, I think of a little wire, and all I think of is, how is that going to
Metal
make a
clothes
baby
hanger, you
out?
tear
They
them
scrape
apart,
it.
they're this long.
They scrape it.
Yeah. I'm just-
They scrape it away from the uterus. Okay?
Change.
No, hang on. Spontaneous abortion technically is a pregnancy that gets terminated before the 20th week. Now, that is actually into your second trimester. Each trimester is 13 and a half weeks by definition. Okay? This usually does occur in the first 3 months. This signifies women are going to go, my gosh, I did something wrong. I shouldn't have, whatever it was. I shouldn't have done this or I shouldn't have done that. But the fact of the matter is, a spontaneous abortion or a miscarriage that happens early in pregnancy is due to improperly developed fetus. So there's something significantly medically wrong with the development of the fetus, and that's why it aborts. Okay? So no, it is not because she did this or that. It is actually part of the development process. Okay?
Isn't there some natural birth defects that a baby can be born with?
Yes,
The body will
of course there are.
Try and abort it?
No.
Recognizes it as a...
The birth defects are later in the pregnancy. So if it happens in the first, again, typically 20 weeks, usually it's, or definition 20 weeks, usually it's much earlier than that. This is the cells stop dividing. This is that kind of, it's for a lack of a better term, it is a gross malformation of the dividing cells. Okay? So, what are you going to have signs and symptoms? Vaginal bleeding, cramping, lower abdominal pain. Essentially, they are in labor. Okay, and that's what the cramping is they're actually delivering. Okay, and then it can be a passage of fetal tissue. Go ahead. So some of the spontaneous abortion complications is that incomplete abortion that we talked about. So anybody who has an abortion has to go in for what they call a DNC. So be aware of that term, and that basically is if she's had a spontaneous abortion, so she miscarried, she actually has to go in and kind of go through the procedure of an abortion just to make sure that they got all the fetal tissue, just to make sure all the fetal tissue was delivered so she doesn't have those complications, those illnesses, if you will.
Actually, a question on one of the quizzes that we had was talking about anatomic pregnancy. When we were going through our shock, it ended up being, I remember
Yep.
at DNC, it was like,
Yeah, drill and ceremony? No, not so much.
What's it actually like the...
You know what? I don't remember what the DNC stands for. It's a, I don't know. It's a acronym for a term. Also, watch for hypovolemia, and then of course infections leading to sepsis. Okay. So what are we going to do for them? Again, emotional support, high concentration of O2, because again she's bleeding. Okay. Shock position, and then yes, you have to transport any tissue to the hospital. Okay. When I worked in the ER once, I had a woman bring a butter dish. She didn't have anything else. You know, she had a partial spontaneous. Okay. Again, provide a lot of emotional support. Some of them may not need it. The last baby that I was there and kind of cut the cord, and she was like, I don't want it. I don't want it. She had no prenatal care. She had no nothing. Young, delivered at home, never told anyone, kind of thing. I don't want the baby. I don't want to hold it. I don't want it. Okay? So, again, the amount of emotional support you're going to need to provide is going to be dependent on the conditions surrounding the pregnancy. Pre-eclampsia. Okay, this is acute hypertension after the 24th week. And this happens in about 5 to 7% of pregnancies. Usually it's the first pregnancy, although now they're finding it's not uncommon for them to have eclampsia in second and subsequent. A long time ago, they used to think it could only happen in the first pregnancy. It can happen in other pregnancies. It's just most often the first. Some other risk factors, for whatever reason, young mothers, no prenatal care, and I think the reason this comes into play is because if she doesn't have prenatal care, she probably is unaware of her medical status anyway. Okay, so she probably has some underlying issues. Multiple gestation. Okay, who can tell me what that is?
More than one baby.
Yep, more than one baby, so twins, triplets, quads, whatever. And then a lower socioeconomic status. Again, I think it's probably because they don't go to the doctor. Maybe they have high blood pressure to start with, okay, et cetera, don't take their medicines. All right? So there's this triad. Don't you love it? There's lots of triads, right? We have triads when it comes to asthma. We have Cushing's triad. So we have another triad to remember. It's easy because it's all threes. Okay? The pre-eclamptic will be hypertensive. They're going to have urine in their, or protein in their urine. So for those of you guys who have ever went to the doctor with your significant other or your wife or whatever, they test her urine every time she goes in. First thing she has to do is go pee in a cup, and they dip it and they check for proteins. Okay? And then the last thing is edema. Again, typically in the face and hands, because all pregnant women get edema in their feet. So look at their hands and their face. Now, they can tell you too, like, my face is so puffy, I don't know why this is. Okay?
Why would they look for protein in urine?
Because that's one of the things. You spill protein.
So is that bad? Or
Yes. In pregnancy, it is bad.
Okay.
In pregnancy, they allow trace protein. Anything more than trace protein is a problem. I've had to do a 24-hour urine collection for every one of my pregnancies because of this.
What do they do if how do they treat it?
Well, we're going to talk about that. So it's
Okay.
going to depend on how bad it is. So a little bit of protein, they're going to watch your blood pressures, and they're going to follow you along and make sure your pressure doesn't get too high, this, that, and the other.
Okay.
So some of it, they may just kind of watch and see.
Okay.
The only cure for this, delivery of the baby, period.
Wow.
This is why they do some preterm deliveries.
Okay.
Okay? So hypertension, I was right. Anything over systolic of 140 or a diastolic of 90, and then 30 points above the patient's normal BP. And they base that on her first visit, typically. Okay? And then edema, particularly of the hands and face. And it, again, presents early in the day because the more we're up, the more edematous we become. And this actually, the reason they check the protein is because it has a severe effect of your kidney function.
Okay.
So when your kidney starts spilling over protein, you have decreased kidney function.
Okay. And I have a question.
Okay.
When you said they check in on the first visit, is that to decide if they're going to be hypertensive or not?
No, that's what they compare it to. So if I go in and my first visit, my systolic pressure is 100. Anytime I get over 130, even though I haven't reached that 140, it's 30 above my normal, that's considered hypertensive for me.
Oh, okay, I see.
Following?
Yeah, I got it now.
Okay, everybody kind of understand that? Excellent. All right, so signs and symptoms. They're going to have a pretty significant weight gain. Now, yes, we expect pregnant women to gain weight, okay? But again, their kidneys aren't functioning. They start to essentially go into like a type of kidney failure. And so they start holding a lot of water, which is why they get so puffy. They are spilling over protein because they're trying to get rid of all this bad stuff that their kidney can't filter well because it's not filtering like it needs to, okay? So anything more than 3 pounds in the second trimester or a pound a week in the third trimester is considered rapid weight gain. Decreased urinary output, again, she may or may not realize it. Headache, blurred vision, absolutely. Again, it's just like any other hypertensive issue or hypertensive crisis. Okay, they're going to have the same signs and symptoms. Nausea, vomiting, they can have epigastric pain. And then even pulmonary edema, again, because they're fluid overloaded. Their kidneys aren't getting rid of the water that they need to get rid of. All right, everybody with me? You doing all right there, Ron?
Yeah.
Excellent. So, complications. Eclampsia, okay? So you have pre-eclampsia, and then a complication would be eclampsia. And we're going to talk about the difference in a second. One thing that makes it different, it's a big thing. Premature separation of the placenta, okay? Stroke, renal damage, pulmonary edema. We already kind of talked about this, and even lower birth weight infants. Okay? So what do we do for them? High flow to left lateral recumbent. Why are they going into the left lateral recumbent position?
So not pressure on the vena cava.
Yep, keeping the baby weight off the vena cava, letting the blood return to the heart. Okay? Avoid excessive stimulation. Watch those bright lights. They may tell you turn the lights down, right? That's because of those visual changes and the headaches that they're getting. Okay? And then, yeah, okay. Eclampsia. This is the gravest form of preeclampsia there is. You'll have all the same signs and symptoms. Once she seizes, Okay? It's eclampsia. Seizures produce eclampsia. Okay? This occurs in less than 1% of pregnancies. Once she starts seizing, she will not stop. Okay? Well, nothing you guys do, but she probably will not stop, probably will not return to baseline. This is absolutely I need ALS here because they're going to give her MAG. That will stop the seizure, and then as soon as they get to the hospital, they're going to do an emergency C-section and remove the baby. That is the only thing. Now, go ahead, because I'm probably getting ahead of myself here. Okay. Yep, grandma seizures or coma. Complications are the same as preeclampsia. Maternal mortality, 10%. Fetal is 25%.
Wow.
Yeah, those are some pretty high rates when you start talking about death or survivability nowadays. You know, it wasn't uncommon probably back in our grandmothers' and great-grandmothers' time to frequently lose babies or mothers due to pregnancy, but a lot of things are different today. Okay? One thing I want to tell you about eclampsia, and listen very carefully. This can happen for up to 6 weeks postpartum. If you go to a house and a woman is seizing and she's never had a seizure before and there are signs of a baby, you need to find out how old the baby is. Okay? It's more likely to happen closer to delivery. Okay? So as you get around that 6-week mark, it's not as likely. Okay? So the further out you go, the less likely it is to become a problem. Okay? But this can happen after delivery. Okay? Again, high flow 2, assist ventilations as needed, because remember they have coma type things. Left lateral recumbent position, reduce the light. Manage like any major seizure until you get assistance, because we have to handle it a little differently. Okay? Emergency transport, and consider ALS. All right? There was something else I was going to tell. Oh. So, and again, I avoid sharing stories, and this one isn't even mine, but I want you to be aware of it. Okay? We had a crew that went out, and the guy called us because his little girlfriend, and she was little. She was tiny. Like, I'm talking Marcy size tiny. She was little, and she was freaking out. She was, like, throwing stuff. She was violent. She was whooping his butt. She was all over the place. She was eclamptic. She had extreme hypertension, and that's why she had ultramental status. Okay? So, second and third trimester, you need to be thinking this. Okay? Yep. Assess them all for increased BP, which we know we're going to get at least 2. Also, watch for that edema. Again, you may just have to ask her, you know, have you noticed any swelling in your hands and face early in the morning? Okay? Take all reports of the seizures in pregnant females very, 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 very seriously. Okay? Again, think about those mortality rates are high, 10 and 25%. Okay? Now 1. Okay, abruptio placenta, okay, is basically premature separation from the placenta from the uterine wall. Okay? High-risk groups are older pregnancies, hypertensive, and then multi-gravida patients. So,
Gravida meaning that they've had multiple children?
yes.
So, multiple pregnancies. Okay.
Mm-hmm.
Okay.
They may have mild to moderate vaginal bleeding. So here's what I'll, because you might go, kind of, how is that? Typically it tears away at the top. So the baby kind of corks it, right? If they don't have cervical dilation, they're going to have minimal blood loss externally. So they may not realize it. So when you say, kind of, are you having any bleeding or vaginal discharge? She may go, like a little bit, it's just a little bit spotting, or she may go, no, not really. That's going to depend on the location of where it's separated. You with me? You understand kind of how it sits in there? Okay? And this is going to be continuous knife-like abdominal pain. Knife-like abdominal pain. Okay? Tender, rigid uterus. Okay? And then they can have signs and symptoms of hypovolemia. Yeah. Well, yeah. I mean, it can. Yes, absolutely.
And it's always going to be from the top? You won't pull
No,
from
not
the
always.
side?
Not always. It depends on where the placenta is attached. So, another tidbit of information. Typically, placenta starts lower and then moves higher. So it depends kind of on where the initial is. right? So if she has, and we're going to learn about placenta previa, if she has placenta previa, then yeah, she's going to have, it's going to be different. So it's all about where it attaches. Typically the uterus is up higher, or I mean the placenta is higher, or on the sides. It can be on the sides, which would explain your moderate bleeding. Okay? So third trimester abdominal pain equals abruption, placenta abruption until proven otherwise. Also, trauma can cause this. Okay?
I did click it. It says hypovolemic shock.
Oh. I was like, what the heck? Yeah, anytime that so if you're if they're showing signs and symptoms of hypovolemic shock and you can't figure out what else, you know, like you're kind of going, she doesn't have any big external bleeding, she doesn't have, you need to be thinking placenta abruption. Okay? All right, what are we going to do for him? High flow 2. You seeing a pattern? Left lateral recumbent position. Still a pattern?
Yeah. Elevated beat.
Typically. Supportive care for hypovolemic shock and rapid transport. Okay? Placenta previa. This is basically where, okay, so here's my cervix. You see my cervix, right? Okay? This is the placenta. And so there's 3 types of placenta previa. There's low-lying, there's moderate, and there's complete. So this is a complete placenta previa. This is where the placenta implants basically over the cervix. Okay? Low or moderate would be up against the cervix as it's closed, and then low-lying is within like 2 centimeters. Okay?
Where's it supposed to be?
Not there.
It's supposed to be like on the opposite wall, right?
It doesn't matter. It doesn't matter.
Floats?
No, it attaches.
Right.
It attaches. But as the uterus grows, then this, if it attaches here, as my uterus grows, see how it changes?
Okay.
That's what I mean by moving.
Low-lying, moderate, and what?
That doesn't matter.
Oh, okay.
You don't need to know that. Go ahead. Okay, so this is typically 3rd trimester, painless, bright red bleeding. Okay? So they usually won't let these ladies start to dilate because this is what happens. As long as my cervix remains closed, not really a problem, right? So as my cervix starts to open and the placenta is laying on top of it, it's now exposing the placenta that's supposed to be attached to the uterus to supply nutrients to the fetus. Y'all kind of see how that is? Okay. It's very common for women to start dilating anytime during the 3rd trimester, and it could take forever for her to go to 10, or she feels like it is.
I have a question though. Wouldn't you be able to see earlier in your pregnancy?
Yes, if they have prenatal care, they know it.
Okay.
If they have prenatal care, it's picked up in an ultrasound.
All right.
Yep. And it's going to be soft, well, as soft as a pregnant belly gets, okay? And that's going to be non-tender. They're going to have not any pain. They're just going to have this bright red bleeding. And typically they will call you either because they know what it is, because they've had, you know, and they said, oh gosh, I started bleeding, I have to go, because that's what the doctor tells us, okay? And then also signs and symptoms of hypovolemia, okay? What are we going to do for them? High flow 2, left lateral recumbent, supportive care for hypovolemic shock. We don't teach you vaginal exams. Don't ever perform a vaginal exam. Okay? Unless she says, I need to push, stay out. Okay? Okay. There you go. Question?
With the placenta previa, you said in that case it was attached to the cervix.
Yes, the placenta attaches to the cervix.
So it's almost like grafting itself to the cervix?
Yes. So when the sperm and the egg meet, right, they immediately start dividing, and it happens at phenomenal rate. They double and they double and they double, and that cell splits, and every cell splits, right? The outer layer that forms in that zygote, because when it implants into the uterus, it is literally a ball of cells. So that outer layer, so it's like an outer layer of cells and then an inner layer of cells by the time it gets there, because it takes days to get to the uterus. That outer layer actually eats away at the uterine wall or lining, which is what causes implantation bleeding. So it eats away at the uterine wall, and that actually becomes the placenta. Those cells literally eat away at it and then implant. They kind of attach. Is this the next one?
Yes, ma'am.
Okay. So uterine rupture is basically tear of the wall of the uterus. Okay? Causes blunt trauma, prolonged labor, okay, against an obstruction, labor against weakened uterine walls. This is why some doctors, and they didn't used to do it at all, did not let women who at one time had to have a C-section, they did not let them attempt vaginal delivery, because once they cut into the cervix, you have a weakened uterus, or I mean, once they cut into the uterine wall to deliver via C-section, that weakens the wall, and so it's more likely that they're going to have this.
Do they change that though?
Yes. They monitor things differently. This can also, placenta previa, or abruption can also happen. Yeah, they call it a VBAC. Abruption can also happen if she has typically like Pitocin, which y'all don't, I mean, it doesn't really matter unless you're doing interfacility transfer. So if they're giving her Pitocin, that can actually cause it, because it causes more forceful contractions. Okay? So this is going to be a tearing abdominal pain. You guys remember what was the other one? Knife-like. So it was stabbing. This one is tearing. Okay? Severe hypovolemic shock, firm, rigid abdomen. You may be able to feel fetal parts at the abdomen. Again, it's going to depend on, kind of the severity and whatnot. Okay? And then vaginal bleeding, again, may or may not be necessary, because remember, she's bleeding into her abdominal cavity. Okay? What are we going to do for her? High flow to and anticipate shock. ALS or helicopter intercept, this is another life threat. Who knew that there was this many life threats when it came to delivering babies? Okay? All right. Yay, now let's talk about emergency childbirth. Do you guys need a break?
No.
Okay, hang on. I got some that are kind of getting antsy, right? Hang on. Excellent. So now we get to talk about one of the best things in the whole world, is this emergency childbirth. So you're in luck, right? Women have been delivering babies on their own for hundreds of years. Typically, they don't have any problems, right? Thank goodness. Most deliveries happen without incident. Now, of course, we're going to hear about the bad ones, right? Of course. Okay? Okay. That's actually how they look. Yes. Yes, it is. Depending on what stage they're at, okay, they can actually look like aliens. I have to show you some pictures later, because you can see babies that were born that are like this big, and that's kind of what they look like.
Yeah, I've seen them. Their eyes are fused, their fingers are fused.
Yeah.
Everything.
Yep. Okay, so there's a placenta, and essentially those little fibers are kind of showing how it kind of attaches to the uterus, okay? There's the umbilical cord, and then the amniotic sac is also called the bag of waters, okay? So when we talk about as your water broke, that's what they're talking about, is this cushiony, protective sac of water that the baby's in. And then, of course, the baby's kind of floating around in there, just chilling out. Huh? Not really. Okay. So when you kind of take a look, you can see the umbilicus, the placenta, the amniotic sac kind of over in that far one. So this is kind of how it looks. Okay? You can see in this picture, the placenta is up kind of on the top side of the uterus. All right? And then the water is kind of just surrounding the baby. All right? And they'll have, where you really see the water, if you ever go for a test, kind of in these spots right here. Okay? And then there's the cervix, or the opening to the uterus, the bladder, there's the pelvic bone, and then there's the rectum. So it's important to understand that. Okay? Go ahead. So there's 3 stages of labor. You should probably know this. 3 stages of labor. First stage is from the onset of contractions till dilation of the cervix is complete. Second stage is from complete dilation to delivery of the baby. Okay? Third is delivery of the baby to delivery of the placenta. Those are your 3 stages of labor. All right? So, what are some signs that we're imminent delivery? So that means What does imminent delivery mean, Mickey?
Coming out now.
Yeah, we probably need to prepare. I mean, like, they typically don't, like, shoot out across the room. But we need to get ready. There are some things we need to do to get ready. So how do we know? Crowning. Okay? That is basically when you look, she's going to feel a lot of pressure. She's maybe going to tell you, hey, here comes the baby, right? So if you haven't seen this before, there's kind of some stages. So if you don't know what you're looking at, you may kind of go, boy, this all looks very swollen down here. Well, it's swollen because the baby's head is pushing and causing everything to kind of bulge. Plus, whenever we go into labor, then the body really starts sending blood to all of the parts so that it can start stretching and kind of be a little bit more flexible, if you will. Okay? Also, rupture of the amniotic sac. That isn't indefinite. Okay? Your water can break for a long, like my water broke at home at 2 o'clock in the morning, and I didn't even start labor for another 2 hours. Okay? The need to bear down. So if they feel like they need to poop or move their bowels, they are feeling the baby pass through that birth canal that's putting pressure on the rectum, which is why they feel that. That's why I was telling you. You remember that picture, how close it is? Well, when it puts pressure on it, that's the same sensation. Okay? And then contractions, typically 1 to 2 minutes apart. They need to be regular, okay, but they don't have to be. And then usually they'll last 45 to 60 seconds. Okay, if they're only lasting like 30 seconds, 45, and then they're back down to 30 and maybe 15, okay, you may have a little bit of time. So once they become regular and they're coming about every 1 to 2 minutes and they're lasting a minute or 45 seconds, that means she's only getting, guys, let's do the math here. She's only getting about 15 seconds of rest. Okay, depending on if she's having contractions a minute apart and they're lasting 45 seconds. Okay, that is not much time. Okay? So, what are we going to do? We're going to position mom, we're going to prepare mom, and then we're going to prep for delivery. Right? Yay, we're going to deliver a baby. This is way better than working some nasty CPR where you're getting puked on and all the bad smells in the dirty house and all this kind of stuff, right? So, how are we going to prep or position mom?
Up, one knee up and one down.
Nope.
Oh, please don't.
Keep the button. So, both knees are up and bent. Mom's going to be laying on her back. Okay? You want to put something kind of up high underneath her and then lower underneath her, right? It's messy. Okay? And then you're going to put drapings on her, like each leg and across her top. Now look, we are in EMS, so we're not going to strip this woman down. If she's got a shirt on and she's got pants on, leave the shirt on. Right? What's the harm in that? Give her some dignity. Okay? This is the baby's head as it presents. All right? So, this is what crowning looks like kind of later as it's actually delivering the head. Okay? So, place the gloved hand kind of on the presenting part to prevent this explosive type delivery. Okay? Don't apply pressure to the fontanelles. What are fontanelles?
The brain, the head.
The soft spot. So babies are born with a skull that is not yet fused. So they may have this little ridge here. Well, that's kind of where the skull gives you the ability to maneuver through the birth canal, right? Okay. So it's real important. They have one here on the top, and they have one, I think, back here. Okay? So as the head presents, if the water hasn't broken, you need to break it away from the baby's face. All right? When the baby delivers, okay, most babies are face down, and they kind of have this natural rotation. Okay? So when they come, as they start to deliver, the head is facing down, and they will start to rotate. Okay? About the time the head comes out and completely delivered, it's kind of sideways. All right? You can't see that picture. Okay. So as the head presents, actually, this says suctioning the mouth and nose is still recommended, and it's not anymore. Okay? We need to kind of update this. Most recent stuff says it is okay not to suction the baby as it's being delivered. All right? It used to be very common, stop pushing, suction the baby's mouth and nose. Not anymore. Okay?
So do we, for testing purposes?
For testing purposes, no. Do not suction.
Okay, like when we do our next test?
Yes.
Okay.
And national registries especially.
Okay.
Okay? And that's because the research doesn't indicate any improvement Some doctors might still do it because old habits die hard, okay? But the recommendation is it doesn't improve anything. Check for a nuchal cord. Who knows what a nuchal cord is? Nope. Anybody else know what a nuchal cord is?
One thing I can think of is around the neck.
That's exactly what it is. Okay? So you have to feel and see if it's around the neck. If it is, and you have enough cord that you can slip it over the baby's head, do so. If you can't, you need to clamp and cut between the clamps.
So we used to just stick our fingers in between and hold it until we finished the delivery. You know what I'm saying?
No.
So you would just. So that was one of the times they said that was the only time you can actually.
You're thinking of something else. We're going to talk about that here in a minute. I think you're thinking of something else. Okay, go ahead.
So it would be like an umbilical cord cut just in advance before
Yep.
the baby's fully delivered?
Yep.
Okay.
So baby, gently kind of guide the baby's head down, and that's for delivery of that upper shoulder, okay? Let that first shoulder present, and then once you lift the baby up a little bit, the other shoulder is just going to kind of deliver, okay? And then you don't need to pull, okay? The baby will typically just kind of come. Make sure you're supporting the body and et cetera, okay? And then note the time the baby delivered, okay? So again, 8 are in the upper shoulder. So you see how it looks? That's why you kind of just guide the baby's head down, okay? And then that first shoulder should deliver, and then once you come up, that second shoulder will follow. Okay? Again, if the amniotic sac hasn't broken, puncture the sac, pull it away from the baby's face. Okay? If the umbilical cord is around the baby's neck, if if it's loose and you can slip it over, fine. If not, clamp it and cut between the clamps. Okay?
What would you puncture the sac with? You just poke it with your finger or something?
Or a pair of scissors.
Okay. That wouldn't be unsanitary with scissors or anything?
It's not sanitary. It's not a sanitary environment once they come out anyway.
Do they still call it the bloody show?
The bloody show is actually the mucus plug, so we'll talk about that for a second. The cervix actually develops this plug of mucus. And I know it sounds disgusting, but you need to be aware of it. Okay, and it's kind of, and that's exactly what it is. It's a plug of mucus. Okay, women can actually expel it several days before they start, but that's a pretty good indicator to ladies that you're about to start. You're about to start going into labor. So as they start to dilate, then the mucus plug kind of falls. It's been told that some women may have more than one mucus plug. So if you drop your mucus plug too early, your body will actually regenerate it. So when they talk about vaginal secretions, it's very common for ladies to have increased secretions during pregnancy for some of those reasons. So yeah, and that just kind of tells her usually it's going to start within a day or so. Ma'am?
Are we not going to go over if the baby's like...
We will.
Okay.
So your warning here is that newborns are slippery, and they are. They're wet, they're slick, they're coated, okay? They look like icky. They're like little Smurfs, okay? But it's a beautiful thing, and embrace it, okay? So again, kind of support the trunk as the baby comes out. It's kind of out of order in it. And then support the legs. Have your partner provide the initial care and monitoring. It is very important that you keep the baby level with the opening of the vagina until the cord is cut. Because guess what? Otherwise, it works like gravity. You hold this baby up here, you're draining the child. Okay? It is important to keep them at the level of the vaginal opening until the cord is cut. Okay? So what are we going to do? Wipe the blood and the mucus from the nose and the mouth. Suction if needed. So if they're gurgling, and you suction the mouth and then the nose. Okay? Warmth is critical. So guys, wherever you're delivering, and I say guys, I mean ladies and gentlemen, okay? If you are delivering a baby in the back of an ambulance, if you are not sweating bullets because you've got the heater up, it is probably too cold for the infant. Okay, this isn't about your comfort. This is about, it's critical for baby. Okay? So wrap baby in a warm towel. Keep the head lower than the trunk. All right, clamp the cord. So the first clamp is going to go about 4 inches from the baby. You can kind of guesstimate that about like this, okay, typically, all right? And then a couple inches further away, I'm going to tell you something that somebody else may not tell you. So you place your first clamp. It's a good idea to kind of milk the cord. Otherwise, when you cut the cord, it will splatter a little bit, okay? So just kind of reduce your risk for. At this point, we've all taken what kind of PPE, do you think?
OB.
Yeah, they actually have OB kits that have full, you know, make sure you've got eye protection and masks and gowns, and it is a very messy process, okay? So again, cut it, then go 2 inches away, and then cut between the clamps. Don't get excited, not know where you're cutting. All right, and then, and these really small babies, they come with clamps, and so once you clamp it shut, if the umbilical cord is really small, it might not provide enough pressure, so then you're going to use umbilical tape. Umbilical tape is not actually tape. It's that flat rope-like string. If you guys seen it in the other room, we use it sometimes to secure ET tubes. Remind me when we go in there for skills, and I'll show you what umbilical tape is. Okay? So after delivery, you need to stimulate the baby. Now, you can flick the feet, okay? Typically, as you're drying the baby to warm them up and to get them dry because they're wet, okay? Typically, that's enough stimulation. You cannot warm the baby up or dry them off like this. This is a vigorous rubbing of this baby. I mean, like, okay? All right. So, stimulate the baby. Don't shake them. Don't slap them on the butt. They don't do that stuff anymore, okay? If the heart rate is under 100, they're going to get blow by O2. If central cyanosis is present, they're going to get blow by O2. Right? Again, when babies come out, they are going to be blue. As you dry them, warm them, and stimulate them, a lot of that should subside. Okay? And then resuscitate if necessary. When do I start compressions? When do I start CPR on a newborn?
Under 60.
Yeah, anytime the heart rate's under 60. And we're going to talk about this progression in just a minute. Back up one. Okay, so this says resuscitate as needed. So this is, but I'm getting ahead of myself. Go ahead. I'm sorry, guys. So observe for delivery of the placenta. Most are going to tell you wait 10 or 20 minutes. If it doesn't deliver, go ahead and transport. Okay? When the placenta delivers, make sure, this is important, you've got to put that either in a tub or a bag. Okay? That has got to be transported with her. Okay? If the placenta doesn't deliver within 10 minutes, go ahead and go. Okay? So there's some things that they look at. Each umbilical cord is a 3-vessel cord, and they look at a lot of things when they look at the placenta. So one of the things they look for is complete delivery. They're going to look at the color. They can actually look at the color and kind of the consistency of the placenta and tell a whole lot about the health of the baby. Okay? This is what it looks like. That's the placenta. Yeah, I know. I should probably shut this door. Go ahead. All right. So what do you do after you deliver? Okay? Lower the mom's knees. Help her hold them together. She's going to be kind of pretty weak. This is a lot of work. Okay? And then, again, make sure you recorded the time of delivery. Resuscitation of the newborn. Now we're going to talk about we know dry, warm, stimulate, suction, provide O2 if their heart rate is less than 100 or they have central cyanosis, right? Okay, now let's get a little further into that. So this is what we call the inverted triangle or the inverted pyramid, okay, of neonatal resuscitation. It is imperative that you understand this triangle, okay, because if you're ever in this situation, it can make a world of difference, right? So the first thing, again, dry, warm positions, suction, and stimulate. Then we're going to give them oxygen. How long do you think we give them oxygen before we reassess to go to our next step of this inverted triangle? 30 seconds. This baby gets 30 seconds to perk up and pink up. Okay? If it doesn't, then you automatically go to BVM. Be very careful. Okay? Fast, small. These babies are highly susceptible to barotrauma, to us causing a pneumothorax. Okay? Very important to be cautious. Okay? After 30 seconds, if they still aren't where they need to be, now we go to chest compressions. Okay? And then intubations and medications come much later. So, breathing efforts. If it's shallow or slow or absent. Okay? So, provide artificial ventilations at 40 to 60 a minute. And then reassess again after 30 seconds and then continue as necessary. Okay? If the heart rate's less than 100 a minute, then you're going to provide Okay. If you give blow-by and the baby doesn't get better, okay, you're going to go to heart rate, right? Anytime the baby's heart rate is less than 60, start compressions. Anywhere between, and it depends, 60, 80, 60 to 100, okay, after you've done blow-by, and then you go to the next step, which is BVM, and if you've BVM'd the baby and the heart rate still is not over 100, that's when you're going to do compressions. Does everybody understand that? So if this baby is not breathing or is breathing shallow, I'm going to give blow-by for 30 seconds. I'm going to reassess. Still not better. I'm going to BVM for 30 seconds. Still not better. I'm going to go to compressions. Okay? And then if no improvement, continue. If the heart rate is less than 60 or 80 and it's not responding to ventilations, again, start compressions at a rate of 120. Okay, so that's kind of what we already talked about. Did I confuse anyone? Okay. If at any time the heart rate's less than 60, again, begin ventilations and compressions immediately. So if the trunk, okay, or the central part of the baby is cyanotic, with adequate breathing and heart rate, administer blow-by O2. So if the baby's blue, but the baby's got a strong cry or is breathing okay and the heart rate's over 100, just give him some blow-by. That's all we need to do. Okay? APGAR scores. This is developed by, conveniently, Virginia APGAR. Okay? This is basically a quick evaluation of the infant's pulmonary, cardiovascular, and neurologic function. Okay? This is done. Well, it's useful in identifying infants' need for resuscitation. However, we don't wait because the APGAR is done at 1 minute after birth and 5 minutes after birth. Okay? So that doesn't mean that we wait for an entire minute to decide if we're going to resuscitate the baby. Everybody understand that? Excellent. So here's how it works. So you can see that the things that we're going to look at is the appearance, the pulse, the grimace, activity, and respirations. And they either get a 0, 1, or 2. It's very common for babies when they're first born to have an 8-9 or a 7-8 APGAR. Okay? So this is basically at 1 minute after birth, what is their appearance? Are they blue everywhere? Are they blue peripherally and pink centrally, or are they pink everywhere? Okay? We're also going to look at pulse. Either they have one, and it's either above and below 100. Okay? Grimace. The baby's making nothing, okay? If the baby's kind of, I don't like the bright lights, okay, maybe, right? So we're going to kind of look at what's their facial expressions. Their muscle tone is really what we're looking at in the face, okay? And then activity, is the baby flaccid, which means just limp, just kind of there? Do they have kind of some, some flexion, or are they actively moving, okay? And then respirations, again, they're not breathing, or they have a weak, slow cry, okay, or do they have a strong cry? All right? Questions on the APGAR score?
So it's either like an 8 or 9 is good?
It's not uncommon to have an 8-9 because it takes babies a lot of times, some time to pink up peripherally.
Okay.
Okay? What's your question?
I'm good now.
Okay.
Figured it out.
Okay. So what are we going to do for mom? Okay, if she's bleeding, put a sterile pad over the vagina. Okay? Do not pack anything. Don't ever. Okay? Don't ever. A loss of 500 cc's of blood is well tolerated. Okay? Again, we develop quite a bit more blood during that second trimester. Okay? And then if bleeding is excessive, we can do a couple of things. 1, we need to rapidly transport. Okay? 2, uterine massage. And actually, you're going to find the fundus. It's usually kind of around the area of the belly button, and it's going to kind of be a hard knot. You may or may not be able to find it, so just kind of feel, and you can start kind of up here, and as you go down, you'll develop that hard knot. That's the top of the uterus, or called the fundus. Okay, so you can massage that. Also, putting baby to breast releases a hormone called pitocin, and it causes uterine contraction, and that's what causes the bleeding to slow down. So both rubbing the fundus and putting baby to breast, absolutely. Okay. If the mom shows signs of shock, okay, high concentration of O2, rapid transport, you may even call ALS intercept. Again, that's going to depend. If it's going to take ALS 10 minutes to get here and I'm 5 minutes from the hospital, are we going to sit and wait? No, you need to go quickly. Okay? And again, this is kind of showing how they're massaging the uterus, and that simulates the contractions. Okay? So let's talk about some complicated deliveries. So there's a breech presentation, okay? And what are we going to do for this? High flow to rapid transport, prepare for resuscitation, and then assist delivery. Breech is basically the butt delivers. Believe it or not, they can deliver that way, okay? But it's prolonged, and that's typically why babies get tired, okay? Plus, one of the things you have to be cautious of is as the uterus contracts, once the main part of the baby is delivered, the head still has to deliver. It's not uncommon for the uterus to kind of clamp down and the baby's head not to deliver effectively. Okay? It also clamps off the umbilical cord, which is problematic. Okay. So if the head doesn't deliver within 3 minutes of the body, this is when you insert your gloved hand up into the uterus. Or, well, it's not really up into the uterus. It's not as far as you think. Okay? And you're going to make this V around the baby's mouth and nose. Okay? That, again, is just taking the pressure off, allowing oxygen and whatnot. Okay? And then push the vaginal wall away from the baby's face to create an airway. That's really all you're doing. You're not pushing on baby. You're just kind of finding his mouth and nose, or hers, and pushing away from it so that way they can have an airway. All right? Limb presentation. This is either a leg or an arm. Okay, position mom. How are we going to position her?
That's what they call us.
What happens if I put mom on her back with her legs up? Where am I putting all the weight? Mm-mm. On the vena cava. Okay. High concentration O2 and rapid transport. Let's see. See who's right. Oh, it didn't tell us. Okay. Yeah, sometimes they will have mom kind of get, not in a squatting position, but kind of elevate the hips.
Yeah.
Right? Kind of down on all fours.
There you go.
Left lateral recumbent is okay. Okay? You're going to have to provide her some support. And it doesn't have to be all the way on her left side. It can be just a little bit of a tilt. She is not going to be comfortable because, remember, an arm or leg is already presented. Okay? And that is one of the times you need to go very quickly. That baby is not going to deliver and it's going to become distressed. All right? Prolapsed cord. Sean, this may have been what you were also thinking about. Okay, this is basically when, and a lot of times if a woman's water is broke, they don't let her get up and walk around and stuff, right? Because if the cord presents first, then it's going to, as the baby presents, it's going to put pressure on the cord. Then the baby's not getting oxygen, it's not getting blood, it's not getting anything. Okay, so that's the big problem here. So what you're going to do is, if the cord presents before the baby, you're going to, again, follow the cord kind of up into the vaginal opening. You're going to put pressure kind of to relieve whatever's putting pressure on the cord. You are there until they deliver via C-section. Or somebody is there. Okay? So high concentration O2, need a chest position or an exaggerated shock position. This is probably also what you were thinking about. And then place the glove hand in the vagina, apply gentle pressure, again, inward to the presenting part, okay, which is typically going to be the head, right? And then relieve pressure on the cord. Okay? Umbilical cord around the neck, we kind of already talked about this. But upon delivery of the head, look for the cord if it's looped around the neck. Okay? If you can slip it over, slip it over. Don't pull on it. Okay? It's fragile. All right? Do not pull on it. So if it can't be slipped over the head, again, clamp in two places and cut between the clamps with some scissors. And then proceed with delivery. Okay? If the amniotic sac is intact, we kind of already talked about this. Use the clamp to tear the sac. Okay? Release the fluid and then kind of pull it away from the baby's mouth and nose. All right? Meconium. Meconium is the first stool of the baby. Okay? This is going to be one of the things you want to ask her, because I kind of don't like that it tells you just to ask her, have you had prenatal care and stuff. I want to know, is your water broke? What's your due date? Are you receiving prenatal care? One of the things I want to know about the water is, did it have a foul smell? It does smell different than urine, okay? But did it have a foul smell, or was it tinged brown or green? Okay? Because that means that the baby is in distress. The meconium is the baby's first stool, and it's dark, tarry, thick. Anybody who's ever changed a baby's first poopy diaper understands what meconium is. Okay? The problem with that is it's thick, it's tarry. It goes into the amniotic sac and into the baby's airway. Okay? Okay. Meconium can again occlude the airway and then cause basically pneumonia. Okay, so avoid stimulation of the baby early to prevent aspiration. Aggressively suction the airway until the meconium is removed. We used to handle this a lot differently. Basically, if the baby's gurgling, suction the mouth and then the nose. If they're not, you don't treat it any differently. Okay? Multiple births. So, consider the possibility if mama's abdomen is still pretty big. Now, for those of you who've never had a woman have a baby, most women do not automatically go back to the normal waistline. Okay? So, when we talk about how big is her abdomen, we're talking like still pregnant abdomen. Okay? So, is it abnormally large prior to delivery? Does it remain pretty large after delivery of the first baby, and then contractions continue? Now, a woman is going to continue having contractions because that's how she delivers the placenta. The contractions, though, at that point are hardly even noticed in comparison to delivery of a baby.
So if you have two babies and two different placentas, right, would you deliver the first, then the baby, the first placenta, and then the second baby?
You don't choose. Typically, you're going to deliver the babies and then the placenta will come.
Okay, I didn't know if you would deliver the first baby in its body. And
But you don't, so what comes is what you deliver.
Okay.
Do you understand what I'm saying?
I didn't know if there was an order it went in or anything crazy like that.
Babies,
Babies.
typically. Because a lot of times, second baby will be born a minute or two after first. Could be 15, but typically it happens.
Is it often that you find people who don't know that they're having twins? Or?
No.
Okay.
This would be the, did you get prenatal care? No, I didn't.
Okay.
Okay? But also, if they know they're delivering, it's not uncommon for them to go, yeah, I know I'm having twins, but they're way early because typically if they have multiple births, they don't go to term. They don't, yeah, they don't go as far. All right, so delivery, clamp the cord, cut it for the first baby, and then delivery, prepare for delivery of the second. Okay? Again, I said it delivers pretty short, depends on sometimes 1 or 2 minutes, sometimes, 5 to 10. And then care for babies and mother, and then the placentas as you would just like a single birth.
Can you put the placentas in the same bucket?
Or would they need to be indicated as separate ones?
I guess if you got 2 buckets, put it in 2 buckets.
Okay.
If you can remember which one came first, the first one's on the bottom, the second one's on the top.
Put it in the pocket.
Okay? So multiple babies, remember, you got to remember they're usually small, and it is especially important to keep them warm. They're going to lose a lot of heat. Okay? So premature infant, by definition, is what? Less than 5.5 pounds.
What?
That doesn't make any sense. Does that say? Am I seeing that right?
Yeah.
That it's less than 28 weeks gestation. Actually, most generally they refer to gestation at 36 to 38 weeks. Okay? They don't stop delivery if they're 36 or beyond.
So should we change this?
Well, no.
Okay.
Just understand. When you talk to a doctor, they're going to say at 36 weeks they'll let them deliver. At 38 weeks they're considered term.
Okay.
But most people go 40 weeks. Okay? Okay, so premature infants, okay, make sure you keep them warm. Make sure the airway is clear. It's not going to be much different, okay? Assist ventilation as needed, resuscitate as needed. All right? Again, watch that umbilical cord bleeding. Remember, like I said, they have potential to be smaller, so your clamp may not completely take care of the bleeding. Okay? Blow by O2, avoid contamination, consider ALS intercept. It'd be nice to have another set of hands, especially if you've got a sick infant or two. Okay? Questions?
Just a comment, I mean, just know that after that baby's born, you have now 2 patients you have to deal with instead of just one.
You absolutely do.
And